So my name's Derek Manis. I'm an assistant professor, and most of my, well, first of all, I'm an epidemiologist, and before COVID, I used to have to define that and state that, no, I do not do anything with the skin. True story. But now everyone knows what an epidemiologist is, I'm guessing. We study the determinants of health and health states across populations. And so I'm also a health services and policy researcher, which means I look at how health services are used and how that relates to the policies that shape health systems to create healthy populations. So my primary areas of research are in home and long-term care. So nursing homes, assisted living, and specifically I look at the health service use and outcomes among the older adults who are in these settings. I look at quality indicators and quality of care, and I also do comparative effectiveness research. So a little bit of background. Why does residential care matter? And I'm sure all of us can look around the room and say that we know of someone who's over the age of 65, maybe 75, or maybe older than that. And if we look at the projections for aging demographics in the US from the OECD, we can see that those aged 65 and older within the next 6 years now is going to well exceed 70,000 in the US. So almost 1 in 3 Americans will be over the age of 65. The old age dependency ratio, which essentially just looks at the proportions of those who are over 65 and not working relative to those who are of the working age, also very steadily increasing. And the share of those 65 and older very sharply increasing. Now, why does this matter? So a little bit of a history lesson. When a lot of our health systems were developed, and in particular Medicare in 1965, there was not the need to have such emphasis on home and long-term care services because most people did not live long into old age with disability. They would have a serious health event, potentially like a heart attack and a stroke potentially, and die thereafter. People weren't recovering from these injuries, requiring long-term care, or living with multimorbidity long into older age. So when we look at the spectrum of settings for home and long-term care, at one end we have home care, which basically can capture anything that someone receives care in their own home. And as we move across the spectrum, we can then see, well, there's community services rather, and day centers. And then we start to move into this really gray area of assisted living that I'll talk about in a bit. And then we move into nursing home care, where individuals are institutionalized and require access to 24-hour nursing and personal care. And a lot of people don't want to go into a nursing home. Many older adults, they want to live in their own home, age on their own terms, and be able to maintain that independence and autonomy over themselves and their care. Right? Everyone's heard the saying, once an adult, twice a child. But that's exactly it. So assisted living throughout the United States and Canada and elsewhere has really expanded because it really addresses the needs and wants that older adults for their home and long-term care services. And it offers this range of services from maybe just supports with meals, medications, and maybe some cooking to moving up across the spectrum to providing more medical-based services, nursing services, dementia and memory care. And it's in the US, it's licensed by every state, and every state has very different requirements for it. Unlike nursing homes that are federally regulated and have federal regulation and standards. And in the research that I've done here, as well as in Canada, we know that those who are in assisted living now and staying there look like those who are in nursing homes. So they are in the mid-80s. Nearly 1 in 3 live with Alzheimer's and related dementias. They're predominantly women. And so these individuals would really benefit from increased oversight to provide them with increased access to primary care, more services to support healthy aging, versus a hodgepodge of regulations that don't necessarily align with the needs, with their clinical needs and profiles. So that's predominantly what I study. And some of the things that my colleagues and I are currently looking at are the use of CNS active or central nervous system active polypharmacy among those in assisted living relative to nursing homes. So in nursing homes, the use of antipsychotics, a CNS active drug, very highly regulated, but not in assisted living. And some of these drugs can come with significant side effects for falls, fractures, as well as strokes. And so those are one quality indicator we're currently looking at. We're also looking at the distress caregivers have for caring for someone in assisted living. And so those are the projects that I currently have underway, but I'm happy to take any questions you might have about the work I'm doing or about why residential care matters, and some of the future areas of research that I see